The Charlotte Ledger Podcast is a member of the Queen City Podcast Network.
Hey, it's Tony Mecia with the Charlotte Ledger, and you're listening to the Charlotte Ledger Podcast. If you haven't already, sign up for our newsletters. They have really good, smart stuff about Charlotte. You can find them at thecharlotteledger.com. Today's podcast is a webinar the Charlotte Ledger held in partnership with OrthoCarolina on August 14th, 2025. It's on arthritis, what it is, how it is diagnosed, and the best advice for preventing it and treating it. It's a really good discussion. It's part 2 of a 3-part webinar series called Move Well, Live Well. Okay, let's get into it. Our guest today is Dr. Michael Bates. Dr. Bates graduated from UVA School of Medicine in 2009. He completed his orthopedic surgery residency at Carolina's Medical Center, received fellowship training in adult joint reconstruction at the Hospital for Special Surgery. With over 16 years of experience, he specializes in hip and knee replacements and complex orthopedic reconstructions. A 2023 top doctor honoree in Charlotte, Dr. Bates brings both academic and clinical expertise to today's webinar. Welcome, Dr. Bates.
Thank you, Tony. Glad to be here.
All right. So, we're talking about arthritis today. I just want to start with sort of a foundational question. I think we all have a sense of what arthritis is. We know, probably have in our heads that as we get older, maybe our joints aren't as agile as they used to be. But what is arthritis?
Yeah, it's probably the most common question that I think I get on a daily basis. So a couple of things. Arthritis is a little bit of a umbrella term because there's many types of arthritis. Now, for today's purposes, and most of the time when people use that word, we are talking about osteoarthritis, which we conveniently shorten down to arthritis, right? But there are other types of arthritis which we are not talking about. We're not talking about rheumatoid arthritis. We're not talking about psoriatic arthritis. We're talking about osteoarthritis. And the simplest way to think about it, it's wear and tear on the joints. Our joints, where two bones come together, they have a protective coating on the ends of the bones. And that protective coating is cartilage. And if you have all of your cartilage, you would never think about it. If you are missing some of your cartilage, you cannot stop thinking about it because it is very painful. So in general, when that cartilage layer has been damaged, either by wear and tear or maybe a previous surgery, maybe you had a traumatic accident as an adolescent, if that cartilage is gone, the underlying bone is then exposed. So when those knees are rubbing when you walk, it leads to inflammation and it leads to pain. So simply put, the lack of cartilage in those joints is arthritis.
Okay, and I know we'll get into a lot of the details and some of the things that you all can do and some of the things that people can do, maybe preventatively. If people have any questions, please drop them in the chat or in the Q&A. What are some of the biggest myths around arthritis?
Well, I think there's a lot. One of them is that some people think that if you're very active, it'll lead to you getting arthritis. We really don't have any data that supports that. So, for instance, we'll have folks that come in, they want to start exercising, and they'll want to come in and check to see, is that okay? Because they don't want to cause themselves arthritis. So we have folks that run as their primary form of exercise, or they bike, or do something that's really exertional from a physical standpoint. We really have no reason to be concerned about those folks getting arthritis any more than a person who's on the other extreme, let's say a couch potato. If anything, we really think that the more active individuals who are doing more exercise, to a moderate degree, you can do too much of anything, obviously, but to a moderate degree, those folks are probably less likely to develop osteoarthritis because they're going to have a healthier weight, and they're going to have stronger muscles, which we know is good for joint health. So that's probably the single biggest one. I think most people do have a pretty accurate general understanding that it is age-related, yes. And another thing is, just because mom or dad had arthritis does not mean that you are going to get it. So there are things that are within each individual's control to decrease the risk of arthritis, regardless of whether or not your mom or dad had it. So that's another myth. It is not a foregone conclusion that you will get it just because your parents had it.
mean, it sounds like it's one of those things that is partially genetic, but also partially lifestyle. Is that right?
That's 100% right. There's definitely a genetic component, but in my day-to-day practice, I would say at least half, if not more, is directly lifestyle related and within the control of the individual.
Mm-hmm. So what happens in the body as arthritis progresses over time? Is it just a gradual wearing away of that cartilage? I mean, what does that look like? And I know that probably people in their 80s are more prone to it than people in their 20s, say. But what is that over time? What does that progression look like?
Well, there's really two ways to look at it. When you are, from the patient standpoint, the way you define your arthritis is going to be based on your symptoms. From an objective standpoint, we're going to be looking at things like x-rays, MRIs, and so forth. So from an x-ray standpoint, what we will see is gradual narrowing of the cartilage, where we can see it, decreasing over the years. And it is a very gradual thing in most people, taking years. Now, a lot of times in the early stages, people won't have symptoms. So they won't start to get symptoms until the point it starts to get to a moderate degree of arthritis or a severe degree of arthritis. Now, from the patient perspective, even though we may have been picking up on it on an x-ray for many years, they don't really become truly aware of it until it starts to limit their abilities. When they start having pain with walking or it wakes them up at nighttime. So sometimes those two timelines don't perfectly line up. But yeah, it's very gradual. Usually, probably in your 50s and beyond where people start to become a little bit aware of it. And then we can definitely see that progression when we take x-rays.
How important is it to intervene early? Like if I think, I'm starting to develop arthritis, is it better to just wait until it's a real problem, or should I come talk to somebody about it? Or how does early intervention affect, the longer term outcomes?
Depends on what you mean by intervention. So for some forms of intervention, it's really much easier to prevent it than to treat it. So early intervention in that regard is extremely helpful. So the best case scenario for me is if I see a person in the office who has mild or early arthritis, a younger individual, let's say they're in their mid 50s, and if we can catch that early and we can find some modifiable risk factors, that individual, we can give them some advice where this doesn't have to progress. If weight is an issue, we will commonly talk about that. And in some instances, if you have a person who can lose a reasonable amount of weight, get their body mass index down into a normal parameter, those folks may never have to seek care again for knee arthritis or something like that. Now, if folks come in and they're already beyond that phase, they're in moderate to severe arthritis, at that point, you do lose some of your options in terms of preventing it. But we still will try to avoid anything that's invasive as long as possible. There's some middle grade options that help people with the pain control, but we're going to always try to prolong the life of the person's knee. Use the knee that you were given as long as it works. But when it comes to early intervention, weight loss is probably number one, and you cannot do it soon enough.
Yeah, you mentioned different risk factors, and it sounds like weight is a big one. And you did mention how to me it seems a little counterintuitive that if you're running, this is one of the myths, right? That if you're running, your bones are going to wear away your cartilage. And actually, I think from what you're saying is actually if you run and you keep your weight reasonable, you're actually more likely to be all right in terms of arthritis. But what are some of those are there other risk factors besides weight?
Yeah, so the big three, weight, I would say, is right up there. The second one is genetics, and that's just you can't pick your genetics. They are what they are.
Yeah.
The third one really comes down to just injuries or things that have happened over a lifetime, right? So folks that had meniscal tears, and not every meniscal tear is the same. So just because you've had a meniscal tear doesn't mean you're at risk for arthritis. But particular meniscal tears can definitely put you at risk for earlier onset osteoarthritis. The genetics do absolutely play a role, but probably the single biggest modifiable one is the weight. It is absolutely at the top of the list, but those are the three. If you've had a fracture in the past that impacts the bone where it comes into the joint, you're going to be at higher risk for arthritis. But that is definitely the exception of the folks we see. That's not many people that fall into that category.
Got it. And, we will be taking people's questions. I see there are already a couple in the Q&A. If anybody online right now would like to ask a question, go ahead, drop it in the Q&A, drop it in the chat. We'll definitely get it asked. I want to talk a little bit about the treatments. Are there any new or emerging treatments that are changing, how we manage the progression of arthritis?
I'd say so. I mean, the main staples of treatment have been pretty stable for some time. There are always things that are on the cusp and are being investigated, but there haven't been any new breakthroughs. We really think about the treatment for arthritis in terms of prevention when it comes to weight loss, muscular strengthening, physical therapy, and that sort of thing. Then once folks get more symptomatic, we start looking at ways to control the symptoms. There's obviously anti-inflammatory medications, some of which are over the counter. Then there are the injections. Now, injections is a bit of an umbrella term. There's many things that fall under that category. And then lastly, people consider surgical treatments. Injections is probably where there's the most research, the most potential. You hear about things like PRP injections, which probably isn't something that we were talking about 10 years ago. The fact of the matter, there's a lot more data that is needed before that can be a blanket recommendation for folks. But there's definitely a lot of attention being given to that form of treatment.
How do you know if you're a candidate for some of those treatments, for injections or surgery?
Well, it really comes down to severity. So one of the sayings that I was taught when I was in residency and fellowship is you treat the patient, you don't treat the x-ray. So most of our treatment decisions are probably based on what the patient tells me. So if a person says, hey, doc, my knee is hurting, but it's not that severe. I can still exercise. I can do activities with my family. We're automatically going to be on the conservative end of treatment, almost regardless of what the x-ray shows us. Now, if a person is having trouble with basic activities like going to work or just being able to sleep at night, then you're probably going to be on kind of more in that middle range of different treatments. So we have to take a combination of the severity of the person's symptoms. We match that up with the objective severity of the arthritis by looking at the x-ray, and we can show the person, hey, yours is severe and your symptoms are severe. That puts you on this end of the spectrum. That's different than a person who says, hey, your x-rays are severe, but your symptoms are quite mild. That individual, even though they have the same x-ray, we would treat them with something much more conservative.
And how do we know, like, if I think I'm starting to show signs of arthritis, at what point should I consider seeing a specialist versus just sort of managing the symptoms at home?
Yeah, that's a good question. I think everyone has a different threshold. Most people don't enjoy, taking time off, going to the doctor's office. I mean, we get it. It's a little bit of a headache. So that threshold just depends on when does it start to bug you enough, right? So there are some really common triggers for people. Some individuals, they will put up with anything until they can't go play golf. And then their world is crashing down, right? They can't get an appointment fast enough. Sometimes it's folks can't keep up with their kids or their grandkids, and they can't pick them up and feel comfortable. And that makes folks get on the phone and make an appointment. But it really comes down to if you tried some reasonable things on your own, you've rested the area that's giving you some discomfort. Maybe you've taken some ibuprofen or something, and it just won't stop nagging. That's when I think people should come and get it checked out. Usually we can give you most of the information you would need with a simple x-ray and an examination. And if you can get that information earlier, you may have the potential to make some changes and avoid, some of the other things that can occur down the road.
Are there any specific activities or exercises that can help slow the progression of arthritis? I know you mentioned resting the inflamed area. That seems to make some sense. But is there anything that people can do, without, taking a bunch of painkillers or having, an injection or something more severe?
Yeah, for sure. And that's where we really like to start. So it's better to not get too pigeonholed into, I must do this exercise or that exercise, because everyone's a little bit different. What I usually tell folks, if you can find a way to get some good cardio exercise, you may have to experiment, but just do something, right? To be honest, I used running as an example earlier just because that's one of the most common questions we get. Does it cause arthritis? But there's no avoiding the fact that it's also a very high impact exercise. And there are probably better things to do that don't put as much stress on your knees, but still give you a good workout. So you think about things like swimming, the elliptical machine. Some people can do exercise bikes with no problem whatsoever, but if they start to run, they get pain. So any of those types of things can be helpful. Weightlifting is really important. So don't skip leg day. It's very important. So you work on your quads, you work on your hamstring, and that's really critical as well. So the good thing about it is you have lots of options. So most people can find something that they enjoy. And it's important to not get too pigeonholed into one exercise. You should cross train. Me personally, I like to run, but I can't run more than 2 or 3 days in a week or I will start to feel it in my joints. So I
Right.
mix it up a little bit. I'll get on my bike and I'll do some cycling, I'll do some running, and I'll do some weight training. So it's important to have a balance because if you do too much of any one particular exercise, you're going to probably get an overuse injury.
Yeah, it seems like good advice. Just find something you like and do that, and also mix it up and not just work the same muscles or joints. What
Absolutely.
is that all related to weight? Is the exercise is this related to keeping the weight off? Is that what that is, or
No,
are there other
it's not
benefits?
just weight. I think weight is a big part of it, but it's also strengthening the muscles, right? So that's why weight training is really important. So when you think about your joints, we'll use the knee joint again. And the knee joint is a little bit particular because intrinsically, that joint does not have a lot of stability. You are very dependent upon your ligaments and your muscles to provide stability to your joint. That is different than, let's say, your hip joint, which natively is very stable because you have this big ball that sits inside of a big socket and it's naturally very stable. So by strengthening the muscles, you actually strengthen the the organs that are responsible for giving you stability of the knee and therefore can either decrease the symptoms of arthritis or prevent the progression of it. So while it does help to get weight off by simply strengthening the muscles that provide stability to the knee joint, that is the other way that it helps folks with arthritis.
Well, that makes a lot of sense. We're getting a couple of questions in the chat, one from Luz and one from anonymous attendee. They're asking, a couple of questions pretty similar. What foods are the best and worst for arthritis? And Luz says, well, what about nutrition, eating habits, specific foods to control inflammation? So I guess it's really foods that are helpful and then foods that you should avoid.
So that is one area where we don't have a lot of direct correlation where we can say a particular food is going to lead to arthritis or is going to prevent arthritis. We do have occasionally some folks who are pretty in tune with their diets, and they will find that if I eat a certain product, they will tend to have aches and pains throughout their entire body. And you can go online, you can see some foods are thought to decrease inflammation naturally, right? There's lots of supplements you can buy that are to decrease inflammation. Some people do find benefit in those things, but generally speaking, we focus more so on making sure you're taking in the appropriate amount of calories, not too many, because that will also lead to weight gain, and not as much attention on picking this food over this other specific food. If you find those things in your diet and you can tell a difference, then it's perfectly fine to act on them. But that is not a general enough finding that I think we can make blanket recommendations.
Okay, so it sounds like it might sort of vary person to person, maybe not a lot of science behind it, or there's no one size fits all. If you
Yeah,
eat this magic vegetable, it will reduce your inflammation.
that is true. And I just think that if people I think it's better to probably back up a little bit and just work on having a healthy diet versus worry too much about picking specific foods to avoid arthritis.
Got it. And I know I'm guessing that a lot of arthritis patients that you see, I'm guessing tend to be older, not all of them. My question is really about young people. Has there been an increase in the number of young people that you're seeing with arthritis? And is there anything, people in their 20s and 30s should be thinking about in regards to arthritis?
To answer your first question, absolutely. We see way younger people with osteoarthritis. Now, when I'm saying younger, getting down to the 40s, definitely in the 50s. Those individuals, it tends to be, off the top of my head, Tony, I'd say 80% of the time associated with excess weight. It's that big of a deal.
Hmm.
It is pretty rare to see folks in their 20s or 30s. Now, that being said, we do see those individuals, but it is usually a special circumstance. That's typically the individual that has some type of pathology in their joints from adolescence and led to them getting arthritis decades sooner than they would have otherwise. So we do see it. But otherwise, when you think about risk factors, the ones that we should spend most of our attention on are the modifiable risk factors. Those are the things like weight we keep going back to. But that's probably been the single biggest thing where we see young people. Weight is being associated.
Got it. We're going to go to a few of the questions. We've got several. Jan asks, she says, I have arthritis on the top of my foot. My podiatrist said surgery was an option, but everyone says foot surgery is a bad idea. Can CBD work for all arthritis? So I guess two parts there. Is foot surgery a bad idea, and can CBD work?
So I'll give you this caveat. I don't do foot surgery personally, but as an orthopedic surgeon, I can tell you that for the right individual, foot surgery can be life-changing in a good way. Foot surgery, I think a lot of people find to be a little bit tougher to recover from. And a lot of that has to do with the fact that your foot is all the way, it's the furthest part from your heart. Obviously it's at the bottom of your leg. So you have lots of swelling and it lasts for weeks to months after surgery. And that really aggravates people. It's also hard to get around. So you see people using those knee scooters. So I don't think there's anything inherently worse about foot surgery than any other type of surgery, aside from the fact that you're going to probably have more significant and longer lasting swelling, and that really does aggravate people. Again, if the symptoms are so severe that you're already limited in your ability to do things you like during the day, that's what you have to balance against the headache of proceeding with the surgery. Now, when it comes to CBD oil, I can really only provide you with anecdotal information because we don't really have any good studies that show that it's effective. I have lots of folks who, they find it and they use it on their own, not something that we prescribe or typically recommend to folks. But I've had certainly people that said it made a big difference for them. We don't see where it has a lot of risk for individuals. So I think it's fine to experiment with those things. But generally speaking, I would just go into it recognizing that it's not really backed by science. But you certainly hear anecdotes where people have found it to be helpful.
Yeah, I mean, for a long time, it wasn't really studied, I think, right, because of prohibitions and federal law. But now you have all these, Delta-9, all kinds of different, hemp-derived things that are similar. There's a bunch out there, and it seems like it's sort of legal. It is legal. Places are selling it. So, but I think it's sort of like your mileage will vary.
That's right.
Some people, I've heard the same thing. Some people swear by it, and others are like, it didn't. Not in relation to arthritis necessarily, but some people like it, and some people don't see a benefit. I think, right?
For sure, and it's one of those things where people are pretty enthusiastic about it, and the bottom line is the stuff really isn't that cheap. I'll usually ask patients, how much does it cost for the CBD oil? It's expensive stuff. So my takeaway is when I see lots of folks, or a fair number of folks, who have spent their hard-earned money on something like that, and then they actually say, despite spending that much money, I'm glad that I did because it has helped me so much. I think that's meaningful. That's not what we consider to be data where I could go tell a bunch of folks, hey, this stuff works, you should use it. It's just an anecdote and it should be taken as such. There's probably an equal number of people who bought it and didn't have a great result. But when things are low risk for the most part, I think those are the treatments where it's okay to give them a try and see if it works for you. And if it didn't, you're probably out of a few bucks, but hopefully nothing worse.
Got it. Okay, the next question is from Linda. She says, there have been recent reports of correction of gait to deal with knee pain, especially turning toes out when walking. Have you seen success with such treatment?
I really hadn't. It's not really something that I've been really seeing consistently. Now, for most individuals, it's really, really challenging to change the way you walk. It's not something that you can do unless you are consciously thinking about that every single step. So that's probably not going to be a durable way for most people to, change arthritis. Now, if you have a particular issue where you do not walk in what we consider to be a standard way, that's a whole different scenario. But for most individuals, the way that you walk is dictated by so many complex factors that I don't think that it's realistic to tell a person that you can change how you walk and mitigate knee arthritis.
Got it. All right, the next question is from Fran. She asks, how does a Baker's cyst behind the knee affect arthritis? And maybe you can explain what that cyst is.
Very, very common question. If you've ever had an MRI of your knee, you probably saw the report that says there is a Baker's cyst, sometimes called a popliteal cyst. The short answer is it doesn't really affect knee arthritis. Most of the time, if you have a Baker's cyst or a popliteal cyst, it is there as a secondary issue, meaning that there is something else in your knee that has led to you having a Baker's cyst. Commonly, arthritis is the primary issue. And then because you have extra swelling in your knee, that fluid has to go somewhere and it tends to find its way to the back of your knee. And then we will diagnose that as a Baker's cyst. But other things can cause them too. You can simply have a small meniscal tear. Doesn't necessarily require any type of treatment. But because of the excess fluid production that is seen in the knee, that fluid will start to seep into the back of the knee where it gets trapped. And when we see that on an MRI, it is termed a Baker's cyst. So if we saw a Baker's cyst, we don't typically recommend treatment of it specifically. But if we see a primary problem that has led to the Baker's cyst, most of our attention is going to be trained on that primary problem.
Got it. We're getting some really good questions in. If you have any questions, drop them in the Q&A or in the chat. The next question is from Jeff. Question is, general ankle aching pain enough to be difficult to walk stairs from an active lifestyle, following high-level pickleball and tennis play to a 14,000 plus step lawn mowing, etc. Any suggestions for prevention or relief?
Yeah, so without seeing you or your x-rays, the first thing that pops in my mind for an active individual who's getting that aching pain is, that sounds a lot like osteoarthritis of the ankle. We've been through that in my family. My father had pretty bad ankle osteoarthritis, and he dealt with it for many, many years before he elected to do surgery to treat it. And that's how his started off. Using a ankle brace can be super helpful. There's different types. Everyone has seen those big black boots that people wear. Those are very awkward. They're hard to walk in. You don't need to go that far. But a lace-up ankle brace, we commonly refer to as an ASO brace. I think that stands for Arizona Stabilization Orthotic. Anyway, those braces can be very helpful because they provide a lot of stability to the ankle, but yet people can wear those when they're being active. You can wear them while you're participating in sports, and you can wear regular sneakers with them. That's probably a good place to start.
Got it. All right. Next question is from Kelly. I like this question. It's about pickleball and arthritis. Can you speak to so many folks starting to play pickleball in their 50s, 60s, and 70s who are not used to such lateral force on their knees? Is this a recipe for pain and aggravating arthritis? I believe it is what did my knee in. I have been to an OrthoCarolina doctor who was helping me through this issue. So a little bit of a plug there for OrthoCarolina. But what about pickleball?
I tell you, it has exploded. So, no, I do not think that pickleball is leading to people getting arthritis. And that goes back to what we said at the beginning, that we really don't have any data that active people have more arthritis than non-active people. If anything, it's probably the other way around. However, there are definitely instances where folks have some arthritis in their knee that we can see on an x-ray that they are simply unaware of. Now, when that individual decides to say, hey, I'm going to go participate in pickleball events, they're going to be at a little bit more likelihood to start to be aware of that pre-existing arthritis, because now they're putting additional stress on their knee that their knee was not dealing with before. So to that individual, they come in, they get an x-ray, we tell them they have arthritis. They say, well, I've been playing pickleball for 6 weeks now. And they look at that as a cause and effect, when the truth of the matter is the knee already had arthritis. You just you weren't asking a lot of your knee in terms of physical activity. And now that you are, you're becoming more aware of it. That being said, at that time, our treatment really focuses on not so much telling you to stop playing pickleball, because we want you to be active. We try to find ways that, despite having some arthritis, you can continue to play pickleball, even if that means you wear a brace, maybe take some ibuprofen. But our goal is for you to continue doing those activities in spite of having mild arthritis. But no, we don't think it's actually causing it, but we do see certainly lots of injuries from pickleball like we see from any sport.
So you're not anti-pickleball per se on that question, but it's
No way.
Okay.
No way. Like if that's your thing, if that's what you love to do, if it's your release, it gets your heart rate up, you enjoy doing it, by all means do it, And if your knees can tolerate it, great. Now you can always get an injury playing pickleball, just like you can doing any other sport like basketball. I mean, there's other things we worry about besides arthritis. There's your Achilles tendons, your patellar tendons, right? There's all types of things, that we can do to our body. So it's always about listening to your body, playing it safe. If you're getting some pain and you're about to go to a pickleball match, maybe skip it that day. Most of the time when we see injuries, people always say the same thing, like, oh, they've been bothering me for 2 weeks, and I knew I shouldn't have played that day, but it was an important game. And that's kind of when people get injuries. So I think if you listen to your body, you probably avoid most of the things that we see.
So if you have an aggravated knee, you've got a little bit of pain, just rest it, ibuprofen.
Yeah. It's okay to take a week or two off and get back to it after that point. I mean, most of us aren't playing at professional levels, and we don't depend on this for our income to pay our bills. So just always keep that in mind, and take a week off, and then you get back at it the next week.
I do like pickleball. It is a fun sport, and people get very competitive about it. And you can see, you can say, well, just don't run as hard, don't shift as hard. But once you get it, that competitive juices going, it's hard to turn them.
That's right.
I have one question, and we're just about done. But if are any other questions out there, please drop them into the Q&A or into the chat. What about weather and climate? Does that actually affect arthritis? Sometimes you hear, oh, it's cold, and so my joints are more inflamed. What's the story with weather and climate? Okay,
so here's the story. Every person thinks that they're crazy, and they're almost scared to even ask that question in the office. It always comes at the end, they're like, I know this is crazy to you, but I feel like when it starts raining here recently in the past couple of weeks, my joints have been aching so much more. It is absolutely a thing. And there's not a day that goes by where we don't have multiple people ask that very question. So it tends to be either rainy weather, cold weather, or both of them. And when you put them both together, it absolutely exacerbates the pain. So a lot of people that do have osteoarthritis find that they can tolerate it much better in the summer months than they can in the winter months. It makes a big difference. It doesn't have any other meaning. It doesn't mean that your arthritis is worse or your arthritis is particularly bad. It's just a very common thing. When the barometric pressure drops, people get way more aches in an arthritic joint.
Okay, good to know. Not a dumb question after all.
It is not. It is not.
Next question is from Timothy. I am a patient of OrthoCarolina. I'm being considered for MBB/RFA pathway for neck and shoulder pain. How safe and effective is this treatment? And maybe, again, if you could explain what that is.
So you're talking about nerve ablation procedures. Safe, yes. Effective, well, it always depends on the source of the pain. So, for instance, when we talk about a person's having pain, we may say knee pain, but we try to get a little bit more specific. You can have knee pain due to things like arthritis. You can have knee pain due to neuropathic causes, meaning that the nerves are generating the pain. So some of the specialists we have within OrthoCarolina, part of what they do is try to distinguish between the two. And if we find that you have one of the types that is more amenable to these somewhat alternative treatments, then nerve ablation procedures can be done. The appealing thing about them is that while they are procedures, they are definitely less invasive. They're not the same as a person having to go have, a shoulder replacement, a knee replacement, ankle replacement. They can provide relief, albeit it's not permanent relief. We call it semi-permanent relief, meaning that a person may get a year of relief. But this very much depends on the exact area of the body and the modality being used to treat it. But generally speaking, we look at those as potentially giving a person long-lasting relief without traditional open surgical procedures.
Okay, got it. That's all the questions I have. That's all the questions we have in the chat. I think it's been a really good discussion. Dr. Bates, any parting thoughts?
Parting thoughts, stay active. Try not to let the joint pain keep you from being active. If a person does have, pain, we will try to do things not to slow you down, but to keep you going. Surgical intervention is always considered the last resort. And in some people, that is the difference in them having to slow down and being able to get back out there. So our goal is for you to be able to stay as active as possible. And we have lots of different things we talk about to individuals based on what their goals are and the severity of the problem.
Great. Well, that sounds like a good point to end it. Thank you very much.
Thank you, Tony.
That's a wrap. This episode of the Charlotte Ledger Podcast is produced by Lindsey Banks.
QueenCityPodcastNetwork.com.